So our presentation is a little bit less sci-fi than the one before us. So we decided to do our journal club on a new study that was published in January 2020 that was comparing conservative versus interventional treatment for spontaneous pneumothorax. So if we just go through what is actually the guideline for a primary spontaneous pneumothorax treatment, the last consensus was actually done in 2001, and they say that if the patient is unstable, then of course we'll go and we'll start with a small chest tube insertion. If the primary spontaneous pneumothorax is the patient is stable and the size of it is rather small, then observation could actually be something that would be taken into account. And they suggest to reassess the patient within 3 to 6 hours and repeat the chest x-ray if there is improvement, or well, at least if there is no worsening of the pneumothorax, then you could actually discharge the patient with a close follow-up. After that, if the size of the spontaneous pneumothorax is large, so in their definition, it was more than 3 centimeters from the apex to the pneumothorax, to the collapsed lung. So in those situations, you should insert a small chest tube and attach it to a Heimlich valve or a water seal device. So with that in mind, I also went through the Rosen, and in the Rosen, they actually say that they agree with that. The only little thing that they add is you could actually do a needle aspiration if the size of the primary spontaneous pneumothorax was actually between 2 and 3 centimeters. They had kind of this little gray zone in which they suggest that you can do this aspiration. So with that in mind, being standard practice, this team of Brown et al. Actually went through, okay, so if we have a large pneumothorax, a primary spontaneous one, could it be considered to actually have something that is more towards what we are actually doing with only observing the smaller ones? What would be the outcome? So in their situation, which they call the primary spontaneous pneumothorax trial, it was a multi-centered, prospective, randomized, open-label, non-inferiority trial, and it was held in Australia and New Zealand in 39 different hospitals in different settings. So if we go through the PICO, the population here was patients that were from 14 to 50 years old, and they had unilateral primary spontaneous pneumothoraces from 32% or more on chest x-ray according to the Collins method of calculating it. The exclusion criteria were either previous primary spontaneous pneumothorax on the same side or a secondary pneumothorax. So considering that it was from acute trauma or underlying lung disease, and also a coexisting hemothorax was another cause of exclusion. Bilateral pneumothorax, also tension pneumothorax, and their vitals definition is the following. So a systolic blood pressure of less than 90 milligrams of mercury, a MAP of less than 60, or a shock index of heart rate on systolic blood pressure greater than 1. Another exclusion was pregnancy at time of enrollment. These social circumstances, which for them would more be with the follow-up. So having an issue with his social situation, making the follow-up, or his needing to go to the hospital for worsening of his situation. If all of those would become harder, then they would exclude him from the study. And also if the patient actually had planned air travel in the next 12 weeks. So in my next slide, just a rapid explanation of the Collin methods that they use to actually calculate the size of the pneumothorax. So if we, in the previous study that actually stated the guidelines, they were just calculating the apex to the collapsed lung. But in the Collins method, it's actually a baseline numbered at 4.2, to which you add the sum of your three distances, the one from the apex to the collapsed lung, the one from the side to the collapsed lung, and from the inferior side to the collapsed lung. You add those and you put in the coefficient of 4.7 and you add it to the 4.2 that's already existent, and then you should have the percentage of pneumothorax, of the size. All right, so that's for the population that was either included or excluded from our study. Now the interventional group, we had actually a good discussion with Seth regarding the fact that in this particular situation, because they were looking at the observation being the non-standard practice, then we could have considered it as the intervention group. But just to make it simpler to everybody to follow, because all of the tables that are used as the intervention group, as the intervention that I will discuss, and the comparison group being the observational group, okay? So in this situation, we'll say that the intervention that they use for the interventional group is the insertion of a small chest tube. So they said less than 12 French, and it was attached to the underwater seal without any suctions. And they would repeat the chest X-ray 1 hour after the insertion. So if I did a quick flow chart of what would happen depending on the situation. So their protocol actually says that if there was any lung re-expansion on the chest X-ray 1 hour after drainage, they would do a second chest X-ray 4 hours after the insertion. And in the meantime, they would close a three-way stopcock valve to see if there was any leak and if the lung would stay expand or if it would recollapse. If after the second chest X-ray, there was still lung re-expansion and the underwater drain had no bubbles, then they would discharge the patient home with adequate analgesia and a written paper on which all the information of standard when to come back and symptoms to watch for. If there was a failure at either the first or the second chest X-ray, then they would actually admit the patient, and the following actions and care would be to the discretion of the clinician taking care of the patient. So this is for the intervention group. Our comparison, which is the thing that they wanted to see if it would work in our situation. So the patients were observed for 4 hours minimum in the ED, and after those 4 hours, the patient will have a repeat chest X-ray. If everything was going well and the pneumothorax was not getting bigger, then they would discharge the patient home with analgesia and those written in the same written instructions. But the patient also needed to have no requirements of supplementary oxygen and being able to walk comfortably. If there was any failure to that, the patient would be hospitalized and observed on the wards. They also said that, of course, if you're comparing some people that you think may not need the chest tube, but down the road may have some complications, they decided to do a list of requirements to actually explain, okay, in this particular situation, we'll do the intervention, but they will stay in the observational cohort, even though they have a chest tube placed in. So what would mandate an intervention in their definition would be clinical significance of the symptoms that would persist. if the patient would still have chest pain or dyspnea preventing mobilization, and that even after adequate analgesia, if the patient was simply unwilling to continue the conservative management, if the patient actually started to become unstable. So then again, they had a set of vitals that was systolic blood pressure under 90, a heart rate over bigger than their systolic blood pressure, a rest rate of 30 or more, saturation that would be less than 90% on room air. And of course, as I mentioned earlier, if the pneumothorax would worsen on chest x-ray, then they would put in the chest tube. The outcome that was their primary outcome for their study was a complete radiographic resolution of the primary spontaneous pneumothorax determined by the treating physician within 8 weeks after randomization. And they had a long list of secondary outcomes that they wanted to see at the same time. So time for symptoms resolution, pneumothorax recurrence within 24 hours after or the chest tube removal, then any adverse events, and they had a specific list of adverse events, then length of stay in hospital, number of invasive procedure, and also number of radiological tests that they were doing, number of days off work, and number of patients that actually required suction or a longer drainage. And they also did a patient satisfaction survey. So if we rapidly go through the randomization was done with the adaptive biased coin technique. And what I really want to show you here with this table is not much the loss to follow-up that was acceptable in their case, but mostly the fact that they assessed for eligibility over 2,600 patients, but only 300 actually were included because of their tight inclusion criteria and mostly the exclusion criteria. So with that in mind, it will indeed affect the reproducibility and the how useful it is in the day-to-day emergency department, but we'll discuss that later on. Also, that I will discuss further down the road, we can see here that they extended their study up to 9 weeks to see if those lost to follow-up that actually just because they had a issue getting disappointment after the 8 week, if they extended to 1 week, 1 more week, so 9 weeks, if they were able to get a little bit more people and if it would change the results. So if we look at the population characteristics, they are fairly all the same. We can also notice that most of them are actually tall and skinny patients, which at the same time goes with the population that gets spontaneous pneumothorax. The only category in which they kind of differ were the smoking habits. Other than that, the characteristics were fairly similar. So if we rapidly go through the results, so our primary outcome, the lung re-expansion within 8 weeks. In the intervention group, they had a 98.5% of re-expansion when compared to 94.4% in the conservative group, which gives us a risk difference of minus 4.1% in an intervention in an interval of minus 8.6 to 0.5. The interval here, it's I'll just do this quick parenthèse, where they actually discussed to have a non-inferiority significance, they should have something that is within a minus 9% difference. So here, having it not touch this minus 9% difference between our intervention and our non-interventional group shows that here it was a statistically significant in this particular situation. Then, as I mentioned before, if we consider the extension up to 9 weeks, so to be able to get those patients that were lost to follow-up, but just because of the time issue, not because they didn't show up, then the percentage of re-expansion would be 98.5% with the intervention, compared to 94.9% with the conservative group, which gives us, again, a risk difference of minus 3.7. And our interval is then again not, sorry, there's a small typo, it's minus 7.9. And then again, it's above the minus 9%, being again significant. The thing is, here they said, okay, let's just consider every loss to follow-up as being a failure to treatment. So the worst case scenario, considering that if everybody that we lost to follow-up actually had a worsening pneumothorax, they noticed that then in those situations, the lung re-expansion would be of 93.5% in the intervention and 82.5% in the conservative treatment group, making then our risk difference of minus 11% being lower than the 9% difference that they would accept to be clinically significant. So in this particular scenario, this did not work. Then if we rapidly go through our secondary outcomes that they studied, could actually divide it into two. The first category are the, yes, of course, you're gonna have more procedures in the patient that actually had a chest tube placed in, rather than just people that you observed for a certain amount of time. So those are kind of straightforward and easy to explain results. The only little thing that I would like to mention is most of their calculation that were done with complications secondary to the placement of the chest tube were done on the number of participants, the total number of participants, even though they didn't get any chest tube in the conservative management. So we can notice here that people who had chest drainage for more than 72 hours were 15 over 162, while actually only 25 of them got a chest tube placed in. So there you could actually ask yourself, is it really the good number that was used? Could it be 15 on 25, making it a little bit higher than the interventional group? But then again, it would be easy to explain just saying that the patient who in the conservative group required chest tube placement were actually, some of them were fairly unstable. So they had to, and they were in less good shape, and therefore maybe requiring more aggressive treatments. But just because they wanted to really see if we change our habit to do conservative, what would be the ratio or the percentage of patient that would require those particular situation, then they decided to keep it on this absolute number of everybody in their conservative management group. So then if we get out of those procedure and we go to more to like, okay, here the hospital stay, there was a good difference, and with a relative risk of 2.8, we could see here there's a good difference between our intervention and our conservative, making the conservative management group with a shorter length of hospital stay within those first 8 weeks. We could also say that they usually have a faster track back to go back to work. And there was also a better appreciation of what their situation was and how they appreciated the care with the conservative management rather than the intervention. So with that in mind, I went into see at the SGEM to get this quality checklist for the to see if this randomized trial was actually solid enough. So if we rapidly go through, the study population included or focused on those in the emergency department. Well, this is a straight yes. The patients were adequately randomized. So again, using the 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 adaptive bias coin technique, then we can say that yes, indeed, they were adequately randomized. The randomization process was concealed. The randomization, yes. Then patients were analyzed in groups to which they were randomized. So yes, they were put into a group. They were analyzed into this one. And even though the patients who actually got the chest tube, the intervention, they still stayed in the group of the conservative management. Then the study patients were recruited consecutively. This is hard to really say. There was no mention in their study or even in the annex of if every single patient that they were able to recruit were all of the patients that actually presented to ED. Possibly, but then again, I can't really say for sure. Then the patients in both groups were similar with respect to the prognostic factors. So then again, when we look at the characteristics of a patient, except for the smoking factor, they were very, very similar. Then all participants were unaware of the group allocation. Unfortunately, no, and for the simple reason that I have yet to see a placebo chest tube insertion. So just because of this type of study, it's fairly hard to create this environment. Then all groups were treated equally except for the intervention. Then again, we have to say no, because as I said earlier, once they were hospitalized, there weren't any standard protocol. It was up to the clinician that was taking care of the patient to do those decisions, and they could have differed for any reason. The follow-up was complete for at least more than 80% in both groups. So then again, yes, there was some loss to follow-up, but not above 20%. And all patients' important outcome were considered. Then again, it was the case. And the treatment effect was large enough and precise enough to be clinically significant. So here also we have to say yes, because the chest tube and the observation were fairly clear enough and precise enough to be. So that would be the end of my part, and I will let Seth go with the his part.
Okay. So for my EBM topic, can you hear me? Yeah? Okay, good. For my EBM topic, they chose to do a logistic regression analysis in this paper for the non-inferiority trial. And I thought I would talk about regression modeling, just the basics, because I don't think we've discussed that in our EBM topics. We won't go into logistic regression modeling, but just some of the more basic aspects of regression. So the basic outline, I just want to talk about what is regression modeling, what are the different types of regression modeling. We'll talk a little bit about the basic math behind regression, because I think it's sort of interesting to understand where the numbers come from and when it's appropriate to use. And then we'll just briefly discuss the outcomes in the PSP trial. So what is regression? There's sort of two times when it's used and two forms in which it's used. The first is as a form of predictive modeling. So trying to understand the relationship between one or more predictor variables on an outcome variable. So an example of that would be, what's the predictive value of troponin to predict an MI? We're not saying that troponin necessarily causes an MI, but we can use that to predict the likelihood of an MI. Or like in Adam's talk, he was talking about trying to predict AKI. Regression modeling could be used with a bunch of predictor variables to assess what's the likelihood that the patient will end up with AKI. It can also be used for forecasting and understanding the causal relationships between variables. So we want to try and say, we're assuming that gender and smoking may interact to predict PE. So we can use that to assess whether those variables, in fact, are significant predictors of a PE as well. So I should, as an emergency clinician, care about regression. It's a fairly common statistical technique, so you'll see it in a lot of journal articles. I think it's reasonable to sort of understand the meaning behind it. It's an important predictive modeling tool, and really some of the math and machinery behind it underpins many of the AI or machine learning algorithms that you're going to hear more and more about in the coming years, I think. And especially with the explosion in predictive modeling that's come with the huge amounts of big data that we have available, you'll see this type of modeling done more and more. So you have to be aware of the variable types that go into a regression. The first type can be a continuous variable. So these are any continuous non-finite numbers. Examples of this might be things like age or hemoglobin. We can also have ordinal variables. So these are categories that have a rank order compared to one another, but they don't have a specific distance between each of them. So a CTAS would be an example of this, where 1 is more sick than a 2, but it's not necessarily as much more sick than a 2 is from a 3. And then you have things like categorical variables that are binary or nominal. And these are groups that are different from one another, but with no specific rank ordering next to each other, like gender or type 1 versus type 2 diabetes. So then types of regression, you can have either a simple or a multiple regression analysis. And a simple basically is simple because it involves only one predictor variable, whereas a multiple regression can involve more than one. That might be 2, but that can be as much as hundreds if you wanted to put them in. And then you have to assess whether it's a linear or a nonlinear relationship between those variables. And that's in terms of the predictors and the parameters within that model. So I think the easiest way to sort of explain it is to go through and look at a worked example. So I just basically found a data set online that was a national nutrition study data set. And I wanted to look at the outcome variable, which is patients' cholesterol levels, and looked at the predictor of fat intake to be able to predict their cholesterol levels. So this is a simple linear regression model with one predictor variable. This is the data set. There's a lot more patients within the data set, but we have all of these items that were collected. And I was particularly interested in just looking at the fat intake and the cholesterol levels of the patients. So the first thing you do is just run a scatter plot to sort of assess what the relationship of those two variables is like. And each of these points represents a patient. And so we can see on the y-axis, we have our cholesterol levels, and on the x-axis, we have our fat intake levels. And it looks like, visually that there's a linear relationship, and that the more fat you consume, the higher your cholesterol levels are likely to be. And another way of looking at that would be just to run a Pearson's R correlation, which again, if you remember, goes from -1 to 1, looking at the strength of the relationship, and an R of 0.71 is a fairly strong relationship between fat and cholesterol. So then essentially what a regression model does is it works with a line of best fit. And this line of best fit is drawn between all of those variables. And it's a line that minimizes the distance between all of these points and that line, which is why it's called a line of best fit. And that's the line that's going to be used within our regression model to make predictions of where patients will be in terms of their regression or their cholesterol. So then you get the basic regression formula that's used in most regression models. And I'll take you through how that fits in with our graph in a second. So you have a response variable, which is your outcome variable, in this case, cholesterol, an intercept, a slope, your regressor variable, so your predictor variable, and then there's always going to be error that's within any model that you do, and you're trying to reduce that error to get a better model. So here we are. If we put this into the graph that we're doing, so we have y, our predictor or our outcome variable, which is cholesterol. The intercept is essentially what the level of your outcome variable would be if the predictor variable was 0. So if a patient consumes 0 fat here, this would be the cholesterol level of that patient. Then you have the slope. So that's the slope of the line that's associated with the predictor variable, which in this case is fat. And then you have error. So each of those points has a certain distance that's away from that best fit line. And the further away those points are from the line of best fit, the more error you have in that model. So a good model, you'll see all of those points clustered along the line of best fit. And a poorly predictive model, you'll see a lot of these that are quite distant from that slope. So then when you run a regression model, the output will be a little bit different in any statistical package that you get, but you're always going to get an estimate for your intercept, which we just talked about, and for your predictors. And those estimates are used to calculate your likelihood or your level of your outcome variable. And then you have a p-value that's associated with each of those that tells you, okay, in this case, fat is a significant predictor variable of cholesterol. So again, you have your intercept. In this case, in this model, it's 29.1. So if the fat intake was nothing, your cholesterol would be 29.1. And then you have your slope, so the degree to which cholesterol goes up with fat intake. So if we put that into the model that we just created, your cholesterol level essentially equals 29.1 plus 2.77 times the level of fat that you take. So for any patient, we can calculate if you ate 80 grams of fat per day, your predicted cholesterol would be this model. You plug in the amount of fat the patient eats, and now you can calculate that the patient who eats 80 grams of fat would have a cholesterol level of 250.71. The next thing you have to ask yourself, well, okay, how accurate is that model? And you do that with calculating the sums of squares. So this is done with, this is the second output you'll get in any regression model. You'll get the coefficients and then an analysis of variance. It has its associated p-value, which just tells you that the entire model is significant. And what we really need to understand is the sums of squares and where those come from. So if we go back to the model that we've been looking at, we draw a line across here, and this is simply the mean of the y. So this is the mean cholesterol levels for the entire sample. And then what we want to do is look at the sums of squares total. So that's the difference between each point and the y mean. And we calculate that for every single point on the graph. Obviously, the program does this for you. It calculates as well for every point, the distance, the sums of squares regression, or for the model, which is the difference between the mean and the predicted value. And then you also get a sums of squares error or residual. And these all have multiple different terms that mean the exact same thing, just to make it more confusing. But that's the error that you have in your model, which again, you want to minimize. And that's done for every single point, and it's summed, which is why it's called a sum of squares. So again, if you go back to your ANOVA table that you get, you have your cholesterol, your sums of squares total for the model. You have your sums of squares regression for the model, and you have your sum of squares error or sum of squares residual for the model. If you divide the model divided by the residual, you get an F value. A higher value is more likely to be significant. So if you reduce the error in your model, you're more likely to have a significant F value and a significant F test. And then you can use that to calculate your R squared, which is a test of how well your model actually fits what it's supposed to be measuring. And again, that R squared is calculated from the sums of squares error over the total. So as you can reduce that, you'll have a better R squared. So in this case, our R squared was the error divided by the total. And what we get is an R squared here of 0.504. And an R squared goes from 0 to 1, and it can be looked at as a percentage of the variability in the cholesterol score. So in this case, we say fat consumption explains 50% of the variation in a patient's cholesterol score, which is pretty good for a single variable to explain cholesterol in patients. Just a quick discussion of how multiple linear regression would work. We have the same model, same concept, except now we have multiple different predictor variables, and they each have their own coefficient term, their own slope that changes. We can't really put that on a graph because then you get into a 3-dimensional, 4-dimensional graph, which is harder to see. But if we wanted to do the same thing, we could now add age and fat and fiber to try and predict cholesterol. You would put that in, each one has their own beta weight, and you would get a new model, which gives you a new intercept and a weight that's associated with each of those variables. In this case, you can see that only fat was a significant predictor of cholesterol, and age and fiber intake didn't actually significantly predict that. And it gives us a model. Again, the intercept is a bit different. Every unit increase of fat increases your cholesterol by 2.8. Every year older a patient is, it increases their cholesterol by 0.1. And every unit intake of fiber that a patient intakes decreases their cholesterol level by 1.16. And that gives you an R-square that wasn't very much different, which makes sense if these aren't significant predictors. So just a couple of caveats. There's assumptions if you're going to be going on and trying to do regression modeling. There are assumptions that have to be met. It has to be a linear model to be a linear regression. It has to follow a normal distribution, and the errors have to have a mean of 0 in a normal distribution as well. And if these assumptions aren't met, you'll get results. It's just that they may not be valid and may not really give you a good picture of what you're trying to predict. So that's our EBM topic. Just briefly back to our article. So overall, I think the spontaneous pneumothorax trial was a well-done trial. It answers an important clinical question of how can we treat patients with spontaneous pneumothoraxes differently. And indeed, we saw that conservative management was non-inferior to a thoracostomy. There were also significantly lower rates of adverse events in the conservative management group as well. Patients were happier with it. Patients had less infections. Patients had lower hospitalizations. And I think that's an important sort of patient-related outcome as well. Strengths, it was multi-centered. It had a relevant question, and it was a well-designed trial. Some issues with it, there were very tight inclusion-exclusion criteria. Like Antoine mentioned, there were over 2,600 patients that were assessed and only 300 met criteria. So really, this is not going to be the vast majority of patients that have a spontaneous pneumothorax. There was no a priori decision for how to treat loss to follow-up patients. So in fact, they didn't have significance in their trial if they counted those patients that were lost to follow-up as failures. So it's sort of a statistically fragile study. They also chose a non-inferiority bound of 90%. This was just based on expert consensus. And it essentially means that even to be a non-inferior trial, 1 in 10 of your patients will still fail that conservative outcome. We discussed it sort of being statistically fragile. It was non-blinded, both to clinician, patient, and radiologist, but that's to be expected. And a fair number in the conservative arm still underwent treatment of 15.4%. Our overall conclusions, nonetheless, I think in a very select group that meets those criteria, it's appropriate to offer conservative management to these patients. It's a good opportunity for sort of patient-focused discussion about the risks and benefits.